their doors and windows are open and their thermostat is turned off. The heat from the core, which was left, now flushes out to the periphery. The peripheral temperature will go up and the core temperature will go down. This phenomenon occurs whether it is a general anesthetic or whether it is a regional anesthetic. Okay? For those women in here who've given birth and who've had an epidural. Okay? Let's think about this. Epidural's put in, right? So from the epidural block down, you have the vasodilation, the doors and the windows going open. But because the hypothalamus is still awake, you can actually have heat production. You can have the demand for heat production. So what is the two most common physical side effects of a woman getting an epidural? Number one, they start going, I feel hot. Okay? It's because the blood from the core, the heated blood from the core, is circulating through the entire periphery. The heat sensors in the skin actually pick up the increase in temperature. And they will say they're hot, they will even sometimes flush. The other thing is that from the block up, because the hypothalamus is still awake, the hypothalamus says, oh, my core temperature dropped, I need to increase heat production. So what does the woman start doing? Shivering. So they say they feel hot, but they're shivering. And it's because of this effect. Gesundheit, bless you. Okay? I'll make sure I covered everything. Oh, the patient on the left, preoperatively. If you take and add heat to the system, it's got to be an active warming device. Brand name is a bear hugger, but it's an active warming. A warm blanket on a patient, a warm blanket adds no heat to the patient. It makes them feel better because their temperature sensors can feel the warmth, but it does not add heat to the core. But if you take this patient over here and you add heat to them, warm IVs, forced air products, contact warming that adds heat to the system, if you give them 30 minutes of active warming, you can gain 1 hour of OR time normothermic. Okay? Yes, ma'am?
At our hospital, we do that. We, through this skip thing, they determined that they would use warm IVs start up there, and we use bear hugger gowns.
Mm-hmm.
And we plug them into the bear hugger before they go to the OR for the whole time that they're waiting. Mm-hmm. And then once we get into the OR, we'll put a warm blanket down for them to lie on, and then we replug the bear hugger gown in.
And has that been effective?
Yes, and they also any case that's longer than an hour, they use the fluid warmer for the IV.
You know why an hour? We're going to get to that in the next slide. The hour is actually kind of interesting. Mm-hmm. Thank you very much. This is a patient's temperature profile under anesthesia. We notice up here, we've got the first 3 dots. So this patient is conscious and vasoconstricted. That patient is in pre-op. Okay? Rolling down the hallway. Dot number 3 is Mr. Anesthesia. So put the patient asleep right here. Look at how quickly that temperature declines. 1 degree below normal, which is the definition of hypothermia, is somewhere in the 30 to 45 minute range. That patient is clinically hypothermic. What's actually happening in your operating room right here? Let's go through what really happens, right? I've been doing it a long time. I've watched you guys. I know what happens. Patient comes in, gets him over on the bed, talking to the patient, everything's going well. Put him to sleep, right? Now, what's happening? Stripped, prepped. What? Stripped, positioned, prepped, draped, and your surgeon's on time, right? Yeah. What? Are all the doctors out of the room? Okay? But what's actually happening to the patient's temperature? The patient's temperature starts declining immediately at induction, because the big misunderstanding about hypothermia is that hypothermia is an anesthesia event. It is not a surgical event. What's your guys' definition of a short surgery? 45 minutes, hour and 15 minutes? Hour or less. That's an hour or less of surgery time. How long is the patient anesthetized?
Usually about an hour and 15, hour and 20.
Yep. I've had some people tell me a short surgery is an hour and a half. So now you're pushing up on 2 hours. It depends on the hospital. There's no standard. There's no consistency. But the big issue is that hypothermia is an anesthesia event. And what's the 1 hour rule? Well, here's what SCIP says and what CMS says. CMS and SCIP say that if you have a surgery that is long, if the patient is under anesthesia longer than 1 hour, and that patient becomes hypothermic, so it's an hour of anesthesia, and they become hypothermic and develop a negative outcome, like an infection, they will not pay for it unless they've used an active warming device. So by putting a bear hugger or something like that on a patient, even if they develop an infection, it's like a free pass. They still get paid for it because you've actively done something to try to prevent the hypothermia. Well, here's what's really interesting. So this patient is vasoconstricted, vasodilated, massive heat loss. Oh, before I go on, they are trying to get that rule of the 1 hour of anesthesia time shortened to 30 minutes of anesthesia time. Well, look where that patient is at 30 minutes if nothing's done to them. They're clinically hypothermic by then. So they're trying to get that in place. This patient's vasoconstricted, vasodilated, the doors of the windows are open, okay? Patient gets down low enough, there's a secondary mechanism to close the doors and the windows. But this patient has not developed any new heat. There's no new heat production occurring for that patient. This patient has a tremendous amount of risk for severely negative outcomes. This patient right here requires more medication to stay sedated. So if anesthesia is putting more medication into that patient, what's going to happen to PACU time? Right? The studies that I've read, the PACU cost to a hospital is between $8 and $15 a minute. And you can increase that by up to 20% by patients getting cold. These patients also are highly susceptible to thermal injury. This tissue is hypothermic and ischemic and does not respond like normal tissue does to temperature challenges. What do I mean by that? Well, let's say that I went to a blanket warmer and pulled out a bag of IV fluid, and it was, let's say 115 degrees, and I put it on my arm right now. It'd feel really warm, right? But what would my body do? My body would dilate all this tissue and increase the blood flow to dissipate the heat and to try to prevent a thermal injury. You know, when I get out of the hot tub, I look like a giant red blob, right? Because that's the body's response to get rid of heat. You do the same thing to a patient who is in this physical state of hypothermic and ischemic, and you'll pull the bag back and possibly the skin with it because the tissue will not respond. So irrigating with unknown fluid temperature, putting bags and bottles as props on patients that are in this condition, thermal injuries, pretty severe burns.
Good question.
Yes, ma'am.
When you were talking about active, what they consider active warming devices, do they consider the IV fluid warmers active warming devices?
IV fluid, irrigation warming, and forced air all fall under the umbrella of active warming. Yes, they do.
Yeah.
The literature says no one methodology will maintain normothermia. The bear hugger alone, IV warming alone, irrigation warming alone, in and of itself, any one of those independently will not. It is actually putting a global thing. We're going to address that in a couple more slides. Okay? Well, maintaining normothermia reduces. And, you know, listing the negative things, we've already gone through them, but surgical wound infections, hospital time, duration of recovery, morbid cardiac outcomes, and then patient shivering. In fact, postoperative patients who are hypothermic and start shivering have a 600% increase in oxygen demand. Think what that's doing to the rest of their body with that kind of demand for an oxygen increase. Okay? Well, All those negative things lead to what? Additional costs. This is one of the reasons, and on the next slide we'll get to some math on why this is still such a big issue for the hospitals. So all those negative things occurred, all of them increase, length of stay, transfusions, additional treatments, etc. So maintaining normothermia does decrease risk of adverse outcomes, but it does save time and money for the three people who are involved, the patients, providers, and payers. On a personal note, I underwent sinus surgery a few years ago, and I was in pre-op, and I'd been giving this, and I would really concentrate when I would talk about this on the payers and the providers, because you guys are the ones taking care of all the work and then the big money issue. And I'm laying there in pre-op and I'm thinking about it, and suddenly it hits me, man, I've got a lot at stake in this. As a patient, what happens if I get an infection? So, it really is all three involved in that. To give you a perspective, the cost of a patient becoming hypothermic is between $2,500 and $7,000 per occurrence. Let's do the math just in our heads. Let's take the middle, $4,500. How many patients become hypothermic? 60 to 90%? Let's use the small number, 60%. Now multiply that times 30 million, which is the number of surgical procedures in this country a year. And suddenly there's a whole lot of zeros on the wrong side of the decimal point. What are hospitals doing? They're developing a temperature management protocol from pre-op to PACU to cover the entire spectrum of care. And they're basing it on clinical evidence. You do not want to be like the hospital. Several years ago, but their written policy for warming their blood was 60 seconds in the microwave. True story. Here's what happened. The old philosophical question, if the tree falls in the woods and nobody hears it, did it really make a sound? Remember the old dial kind of microwaves from years ago? You dial them and they'd come up and they'd do what? They'd ding one time, right? Well, anesthesia called for blood. Nurse A went and got a bag of blood, put it in the microwave, turned it on, and walked away. Okay? Anesthesia, where's my blood? Nurse B went to get the blood. Nurse B made a judgment call that blood had not been turned on. Gave it a second dose of radiation, ruptured all the red blood cells, was given to the patient who did expire. Okay? Basing active warming, looking at irrigation, looking at IVs, looking at operating rooms, looking at effective and accurate temperature monitoring, but doing that based on the clinical evidence. There's enough information out there that this information should be implemented, and it is being, as she said earlier, every one of her patients gets bear huggers and warm IVs from start to end. What hospital is that? I may want to go to.
Virginia Hospital Center in Arlington, Virginia.
Okay. Oh, really?
Yeah.
Wow.
That's
Right, I live right there. I live right there. In fact, I've given this presentation at that hospital.
I know.
Okay. Does anybody else remember me? Okay. Drilling down a little bit, looking at the methods of warming, looking at addressing patient safety. Heating cabinets, for years, how high did you guys have those heating cabinets? How high were they? 140, 150? Why? Because everything that came out cooled down, right? So we knew it was going to cool down in the operating room, so let's turn it up. Has anybody ever taken a bottle out and it was so hot that they couldn't hold it? Or a bag? Well, there's an organization out there called ECRI. They, the best that I can equate them is they're like the Consumer Reports of Healthcare. And they came out and said, you know what, these cabinets are so high and there are so many people getting burned, honest to goodness burns, that we recommend they be turned down to 110 degrees for patient safety concerns. Do you guys know if that's pretty much what your hospital's doing now? One time say no. Is anybody not doing that now? I still get a few people in the Northeast who are a little stubborn that don't do that. But it's because of the patients having been burned. Does anybody remember the bear hugger issues with the not using the blankets hosing patients? You guys ever seen those pictures? Yeah, it's pretty rough.